Telfer and the Themes and Partnerships Manager at the Pankhurst Institute. I'll be chairing the session today. Unfortunately, Alex, the director, was going to chair, but you can no longer make it. So the purpose of this seminar was basically to showcase the projects that we funded at this time last year. We funded around 6 to 8 months worth of work. The projects all exemplified collaborative development, evaluation, implementation of health technologies. And the Pankhurst will be offering some funding next year for Pankhurst Fellows. The application process will come out in Q1 next year. So if you receive our newsletter, then you'll get updates about that. And each fellow will be awarded around 7.5k of seed corn funds. And we've also got Sabina here today from the Industrial Biotechnology Innovation Catalyst. And Sabina's going to tell us about some funding opportunities. First up, yeah.
Thanks. That's Nicola. So yeah, I'm Sabina Hawthornthwaite. I'm from IBIC, the Industrial Biotechnology Innovation Catalyst. I'm the Programme Manager for IBIC. I've been in post since July. So a little bit about it. We're funded by EPSRC, the Engineering and Physical Sciences Research Council, you probably mostly are familiar with. And it's their place-based impact acceleration account funding. So it's basically to get research from the university out of the university into industry or into product services and so on. So we've been given £5 million over 4 years. And the PI is Professor Aileen Miller, who is a professor of bioengineering in chemical engineering. She's also the Associate Dean in the Faculty of Science and Engineering for Business Engagement. So our vision for IBIC is to supercharge the Northwest regional economy in terms of the bioeconomy, developing careers, businesses and growth across the Northwest region. So the place-based bit of the funding means that we want to make an impact here in the Northwest, and that is from Greater Manchester, Liverpool, Cheshire regions. So our partnerships are with Salford University, MMU, Liverpool, John Moores and Liverpool University, as well as the science campuses at Daresbury. And we also have on board the 2 sort of civic partners in terms of Greater Manchester Business Board and the Liverpool City region. So we've brought together academia and civic organisations and science parks, and also a whole host of small and large companies across the Northwest who were initial partners on the bid that went into EPSRC. And we also have a couple of venture capitalists there as well who are partners, so that as our projects start to gain traction through the innovation side, they'll be looking at sort of maybe seed corn funding or further investment along the way. We also partner with what was previously known as Innovation District Manchester. You might heard of ID Manchester, which has recently been relaunched as Sister in the old Unister campus up near Sackville Street. So we partner with those, and I believe that Pankhurst are also involved with Sister as well. So yeah, supercharging the Northwest bioeconomy. So basically we've got £5 million to spend over 4 years. So what we want to do with that is to build new partnerships. We want to accelerate the knowledge that's here in the university and the capability out into industry. We want to generate economic impact from that. And then we also want to look at the future bioeconomy and what's needed in terms of skills and workforce, and also regulation and policy drivers. So we've got various pots of money. The partnership ones are things like clustering and networking, building new relationships. We've got some seed corn funding for that. We're going to be running some innovation labs in the new year, industry visits, influencing policymakers and so on. Knowledge exchange is more about what's happened with the research and getting that research out. So it's proof of concept, it's looking at secondments bilaterally, either from academia to industry or industry into academia. And then we also have a big pot of money to develop some strategic partnerships with industry and some funding to look at policy and influencing. So we've been doing a bit of surveying, looking at foresight across what's needed in the region and what's actually happening in the region. And then we want to create impact from our research. So we've been doing some specific programs for early career researchers. We've got a Researcher to Innovator program running at the university. And we also set up a dedicated IBIC which is Innovation and Commercialisation of University Research. It's a BBSRC program and has 4 different types of program: engage, discover, explore. And for each one, you kind of start at one level and you get a little bit more funding as you go up towards sort of innovation activity. So we did an IQ or Discover program. We took on 10 teams, and we have the sort of final session of that at the end of November, where it's like a pitching and options roundabout day, where the people who've done the programme get tailored advice as to the next step of their innovation journey, whether that's looking more at the market development, looking at sort of seed corn funding, or more significant levels of funding. And then, as I mentioned before, we want to look at skills. We want to have a network of expert mentors. We want to look at the region's universities developing specific CPD to help industry develop the skills that they don't have for maybe a future bioeconomy. And also it involves public research, public outreach, and also looking at things that the further education colleges might do, whether it's apprenticeships or linking university courses to the further education colleges. So yeah, we've got lots of money. We also have money for about £500,000 to allow organisations outside of the North West to collaborate, so long as the impact is happens in the North West, basically. So we could have someone from Nottingham work with Manchester University, so long as whatever happens, happens in GM or Liverpool or Cheshire. So the 4 funds we've got at the moment, we kind of run them concurrently. We had our first call come out in the summer, and it closed in September. We have the second call out at the moment, and that closes in early December. And then next year we will run 4 further calls approximately every quarter. So as I mentioned before, we've got money for partnership development, where it's a sort of a one-to-one relationship over 6 months to build that new relationship, to discuss what the research has happened and how that might address a challenge within industry. Similar to Pankhurst's ethos here, where you're looking at sort of unmet needs, we're looking at the same sort of thing, but for the bio industry. And then we've got funding to build clusters and networks, so that could be workshops, or it could be innovation labs, or it could be sort of doing a bit of policy development or looking at skills training. Then we've got innovation acceleration, which is looking at proof of concept. So we've got up to £30,000 for up to 12 months to develop your proof of concept and get it to show that it works in an industry setting. And we've got, as I mentioned before, the secondment exchanges, which are up to a year, there's £60,000 to put those in place, and that's for knowledge and skills exchange between industry and academia. So I should say that all the money that we have goes to the university partner. We're not allowed to give it to industry because of EPSRC rules. So the money goes to the academic partner, and we expect to sort of gain a bit of leverage, either in kind or actual funding from the industry partner through these. And that's it really. So we're here at the university, we're based in MIB. We work across the whole university here. We also work with partners at Liverpool, Salford. We're not just a Manchester-centric project. So if you have partners that you want to develop things with, or you've got an idea for something that is relevant to the industrial biotechnology sector in the North West, then please do get in touch. And any questions? Deathly silence. So just to explain, industrial biotechnology in this context is looking at using sort of bioprocesses or biomaterials to replace, say, fossil fuels, raw materials, new processes. So instead of like making something by heating it up in a big pot, you might do it by fermentation methods instead. So it's looking at replacing fossil fuels within the Northwest economy and using a bio-based ingredient instead. That's kind of boils it down to quite simplistic terms, but that's what we're about. Yeah, so we've got some quite ambitious targets. We hope to build 25 early stage companies, 10 spin-outs, impact on at least 200 students trained in industrial biotechnology, and have 80 proof of concept studies, all within 4 years. So I think you'll agree it's quite a lot to try and achieve. And this is the IBIC team at our launch earlier this year. And I think that's me. Can I also, just while I'm here, yeah, just give a little plug. So the university in the last year has set up something called the Innovation Academy. It's an umbrella organisation within the university for anyone at the university who is interested in innovation from their research. So it's open from PhDs through to early career researchers through to academics. They run seminar programs, they have founders dinners, so people who founded their own companies and spin-outs are brought together. This is not industrial biotechnology either, it's across the whole gamut of the university's research. So it's looking at helping anyone who's interested in innovation to take the next step on that journey, whatever it might be. And it's in close collaboration with Innovation Factory and the Masood Centre at the university. So if you're interested in the Innovation Academy, we have Lisa here in the room. Please come and say hello to her during the break and find out more. And if you're interested in IBIC, come and talk to me. Thanks, Lisa. Thanks, Nicola.
You're welcome. Thank you. So now we're going to get into the CCON project presentation. So Ben, first. I'm just going to check I've set this up right, and I'll actually fill in the screen as well.
Yeah, well, I'll just be okay. Good morning, everyone. My name's Ben Dickie. I'm a senior experimental officer based in the Faculty of Biology, Medicine and Health. And over the last year or so, I've been working with Mike Avery, who's an application scientist in the Henry Royce Institute, to develop phantoms or test objects for deuterium metabolic imaging using a novel printable silicon formulation. So there's a big problem in medical imaging, multi-site medical imaging studies, in that commercial MRI scanners or CT scanners, whatever instrument the imaging study is using, they have lots of differences between sites. So we have to find a way of testing whether the results are the same from one site to another. And often we use something called a phantom or a test object to do this. Most phantoms are kind of static gelatin-based objects which don't really capture differences between scanners, or relevant differences between scanners. And we've been working on a new material that's based on silicon, printable silicon that has kind of elastic properties. So this enables us to print realistic geometries and also simulate motion that might occur in human body. Our previous work has demonstrated that we can tune the T1 and T2 relaxation times of these phantoms. So these are MRI properties that alter the contrast based on mixing silicone, or I'll call it PDMS from now on, with a second phase material. I'm not going to elaborate on what that is because it's kind of ongoing application at the moment. So we've demonstrated we can tune T1 and T2. So this project was to try and apply this new material to a novel type of imaging technique called deuterium metabolic imaging. In vivo metabolic imaging is important to understand the natural history of cancers and neurodegenerative diseases and many other conditions. And deuterium metabolic imaging is a new MRI method that's capable of measuring tissue or tumour sugar usage based on detecting deuterons in administered deuterated sugars. So what we tend to do is get deuterated compound sugar, like deuterated glucose, inject or ingest this compound, and then monitor as it's taken up into tissue of interest. And this particular technique has advantages over existing methods because the natural abundance of deuterium is very, very low. So we can very easily track the tracer that we're administering because we don't have any background signal. And this on the right is an image of, move this down, is an image of the NMR spectrum of after administration of deuterated glucose, and we can see there's a natural water peak. This is kind of the natural abundance of deuterium in the body, a glucose peak, a GLX peak, and a lactate peak. So these are the metabolites of the deuterated glucose, and over time, the height of these peaks will modulate as glucose is converted into metabolites. So again, there's a need for the test objects for this new type of MRI scan to try and measure the consistency of DMI between MRI scanners at different sites, to determine DMI calibration curves for accurate quantification of metabolite concentrations. So to convert the peak of these, the heights of these peaks to actual concentrations in vivo, and to provide kind of platforms or tools to develop these DMI techniques without having to scan humans or rodents. And on the bottom right is an image of effectively this spectrum, but mapped over space. So we can use a technique called chemical shift imaging to measure this spectra at every pixel within the brain or tissue of interest, and actually map these metabolites or spatially across the tissue of interest. So the aims of the seed cord funding were to use our existing formulation of silicone material to develop a prototype printable silicone DMI phantom, and to test the long-term stability of these DMI signals in silicone versus gelatin. So gelatin's a kind of gold standard phantom material. To study the effects of adding glucose or sugar to these phantoms and whether that changes, I'll say, kind of deteriorates. To test how sensitive they are to temperature fluctuations, because if we send phantoms to one place, it might be at different temperatures to another. And so we need kind of a fairly insensitive, a phantom that's fairly insensitive to temperature. And then to distribute these phantoms to partner sites to test the consistency of these DMI signals across scans. Unfortunately, the actual piece of hardware which we needed to do the deuterium imaging kind of broke effectively, and it was out for repair for 3 or 4 months. So we had to kind of rethink some of these objectives a little bit by still kind of progressing the project forward in the direction we wanted to go in. So instead of measuring the stability of deuterium signals, I'm going to present some stability of water proton T1 and T2 signals, the temperature sensitivity of T1 and T2, and then some prototype deuterated glucose phantom data that we collected at the end once we had the coil back. So on the left, these are some of the results. So on the left-hand side, you can see the results of the gold standard gelatin phantoms. So this is the material commonly used to make test objects for MRI. And on the right is our PDMS phantom. And this shows how the T1 relaxation time, which is a property of a tissue property which influences the contrast in MRI images, how that varies across the course of 15 weeks or so. And the gelatin phantoms tend to decrease gradually over time, but stay within a range of about 20%. The PDMS phantoms seem to show a similar kind of trend, but do actually have a slightly lower variability over time. The PDMS phantoms also seem to have a lower T1, and increasing the glucose concentration also lowers T1. What's kind of important to note here is that we also scanned a kind of commercially available phantom as a reference. So that's this Eurospin reference phantom. And you can see that that phantom is reasonably stable. And so our phantom and the gelatin phantoms that we have created are not quite doing as well as the Eurospin phantom. And that's possibly due to not including kind of preservatives within the phantom formulation, but we didn't want to do that. So looking at another parameter, T2, we see a similar kind of trend. So in this case, the PDMS on the right, the silicone phantoms actually appear to have quite a better stability than the gelatin phantoms. So looking now at how T1 and T2 varies with temperature. So in this experiment, we placed the phantoms within the MRI scanner and had a temperature thermocouple and a hot air blower, which effectively we could set the temperature to blow whatever temperature we wanted. And we created a kind of step function in temperature, and that's what this green line shows. So 40% change in the temperature. So it went from about 25 degrees to 35 degrees. And you can see that this changes very rapidly. But the response of all of the phantoms to this change in temperature, particularly for T1, is quite slow. We found that the silicone phantoms that were kind of mixed with kind of more of the phase 2 material tended to have a lower sensitivity to temperature. So this might be something going forward, and actually lower sensitivity than gelatin. And for T2, it didn't seem to show any temperature variability at all, which was promising. Okay, so finally, I just wanted to show an example of some of the data we collected at the end of the project when we got this oil back from the supplier fixed. And this shows a phantom that contains water and deuterated glucose. And we're able to see here the water peak here, which was at about 10 millimolar, and a deuterated glucose peak at about 30 millimolar, and an image of this deuterated glucose peak. And these are the different, this is scanning across the frequencies. So this is frequency on this is scanning across the frequencies. So as we move across this peak, we can see the signal of this circular test object increase and then decrease again. So to summarize, adding glucose to phantoms seems to affect T1 and T2, so this might be something we need to consider going forward. Silicone phantoms showed some improvement in the T1 and T2 stability over a 15-week period compared to gelatin phantoms, but it appears like we need to try and refine this formulation a little bit to kind of get it to the same standard of existing commercial phantoms. All the phantoms showed a delayed response to sharp temperature changes. So this indicates that it may not be such an issue as long as we can keep the temperature at a kind of steady level. And intermediate proportions of silicone with the phase 2 material were most effective at reducing T1 changes. So looking forwards, we are currently submitting as part of an EU Marie Curie Research Training Network grant, which is a big grant on just focused on deuterium MRI with about 15 partner institutes across the EU. And this will provide funding for a PhD student to try and drive this forward. And importantly, it will provide a kind of network of collaborators that are all doing this type of imaging to allow us to test these phantoms on multiple systems across the network. Yeah, we'll hear about that in the summer. So thank you to Pankhurst for funding the work. And does anyone got any questions? Yeah.
Okay.
Hi.
You're looking at temperature within the scanner, is that right?
Yes.
What about changes like if you're shipping it off somewhere and it's freezing or something?
It's freezing. Yeah.
Does the material itself change with temperature?
Refer that to Mike. I don't think you've ever frozen it, have you?
No, we've never frozen it. We've looked more at room temperature and then elevated. So kind of 20 up to sort of 40 is the kind of typical scanning range. I don't think he wanted to scan many frozen people.
No, probably
it's
not.
Something
But,
interesting to look into. Yeah.
I guess
Yeah,
if
whether it'd be
you
great.
deploy these to different sites, then you might not have control of the shipping conditions or something.
Oh, I see. Yeah.
Yeah.
If we froze it,
Yeah,
then
and then thawed.
Yeah. Okay. Yeah.
Just
No. Yeah. Not testified.
Yeah, I don't know if the silicone would actually degrade if you froze it. I don't know.
I'm sure it might shatter. And
Shatter. Yeah, okay. Maybe not good. Something to think about. Yeah, thank you.
Yeah.
Any other questions? No? Okay, thanks, Ben.
Thanks.
So next I think we've got HyperCheat, Simon Harper.
Yeah.
Yeah. Hello.
Hi, you've got the slides here, right?
Yes, I think so. Yeah.
Hi, I'm Simon. I want to chat to you today about HyperCheat. So the only thing that links the previous presentation, this one, is glucose, funnily enough, but that's the only linkage there is, I can see. So this is really about understanding whether algorithms we created for something called congenital hyperinsulinism can be applied to type 1 diabetes. That's pretty much where we're going. So let me just explain a bit about it. So 40,000 or 400,000 people in the UK have type 1 diabetes, and they have to balance around 46 different factors every day to be able to keep within the healthy range. Going above the healthy range means that you've got problems in 20 years. Going below the healthy range means that you've got problems in 2 hours. So that's where we're trying to keep people. And people find that they're scared of being low because there's a problem, within an hour or two. So they stay high, and that means that they keep, that they're high a lot, and that means that there's problems down the line. The guidance at the moment is that you weigh your carbohydrates pretty much. So generally, it's pretty onerous activity, right? So generally, all the time, you're weighing your carbohydrates before you eat anything. You're injecting insulin, and you probably have to understand what you're going to eat maybe an hour before you're going to eat it, so that you can inject the insulin, which is slow acting. Even though it's called rapid, it's not rapid, and then move on. This means there's 180 extra health-related decisions people have to make every day, increases stress and fatigue. 50% of people don't even open the app that tells them what their blood glucose levels are, because they just can't be bothered with it. 30% don't switch on the alarms, so if they go low, they can have a seizure and die within an hour, but they don't want the alarms to be going off because they go up a lot. And the meal insulin is given incorrectly, so 30% of the estimated insulin is incorrectly dosed. 16 years life expectancy is a reduction, and it costs the NHS about 3 billion in avoidable hospital treatments a year. So that's the general idea. Geeks like me think, oh look, data, love data, lots of data. Let's play with data. That's great. But real people think diabetes is crap. They don't want to look at the data. They don't think that the graphs are really nice and pretty. They don't see anything in the 14 pages that you get as a report at the end of every month, so you can look at your own diabetes and understand what's going on. They just don't like it. Okay, clinicians don't have enough time to look at this data, so they just look at the minimal amount because there's too much of it. So what we wanted to do was remove all of this stress from people with type 1 diabetes, but we started to do it in this niche kind of area called congenital hyperinsulinism, whereby it affects about 1,000 people, 1,000 children every year, and it's something whereby you have to catch it very early. So if you don't catch it very early, within a day or two of being born, you die. Otherwise, there's brain damage that can happen. So about half and half, half survive, and that's what we're trying to. That's what we were looking at. This is HyperCheat. So we're trying to stop hypoglycemic events for people with congenital hyperinsulinism. And you can see on one side, on the left-hand side, this is the general report that you get back, where it says no patterns found over a 4-week period, because it's just loaded graphs. But our algorithmics let us see clusters whereby hypos are happening on a regular basis. And what we try to do is send text messages to people to say, oh, I wonder why that's happening. Here's a hypo on Saturday morning. Wonder why that's happening. What's going on? And think about this. Think about your behaviour and activity. We don't give them that. We give them it via WhatsApp. We give it via SMS. We give it them via Discord, whatever they like. So generally, there's not another app. It's just a conversation. They just with the machine they see, and we only give it them once a week. So doing this, we reduced hypoglycemic events across everybody by 25%, and by the worst by 62%. And so that means that this is better than the gold standard, which is typically 16%. At the moment, there's a thing called closed loop systems for people with diabetes. And these say they give you a 16% boost on your time in range. So we're doing 25% by just this. So we thought, we can do lows in this particular niche area. Can we do highs for people with type 1 diabetes? Because then we get 400,000 people in the UK, 8.4 million globally, and it costs nothing, as opposed to the standard systems, which cost 6,000 to 8,000 a year for a pump system. And this was directly cut from our grant. So could we leverage what we've already got, what we've already done in HyperCheat, and can we then use it so that we kind of change the algorithms so we can sort of do something interesting with type 1 diabetes, and can we help there? And the answer is yes. So this is a report. This was one of our reports that we got, and of course this looks terrible. So if we were giving this to a patient, they'd be like, "Oh my God, this is a disaster." It is a disaster, actually. I mean, there's no getting out of it yet, but it's not useful to help people change their behaviour or focus on what the problem is. So when we showed this to clinicians, they said, "Yeah, this is great for us. We really love this because we can see what's going on, but it's no good for patients," which of course it isn't. So what we did was we changed it to just focus on the most clinically relevant cluster. And the idea is that month on month, we would hit each cluster and then try and pull everything down, okay, by hitting all of the worst clusters one after the next. And we give them something to think about. So yeah, you may want to focus on the time between 1 and 5 on a Sunday. There was hypoglycemia at this time for around 4 weeks out of your 4-week period. So they were always high at this time. Why? Probably they're having Sunday lunch or something and they're not treating themselves for it early enough. But this just means that they can think, oh, well, maybe I'll need to do something about this. So once they hit this, they can move to the next one. We also found with people it was useful to look at the time every day. So instead of it being a weekly thing, it was just where do you need to focus every day? And we found that, yeah, they were bad every day around lunchtime. So what it says is that they didn't understand they needed to give themselves insulin, or they're giving themselves too little insulin when they're having lunch, when they're having their meal in the day, in the middle of the day. So therefore, can we actually do something about that? And then this was another report whereby the clinicians wanted this, which was called rebound. So they have a low, they overtreat because they're freaking out, which of course you would do. And then you give yourself too much because you want to be safe, and then you get this rebound. And it always happens it always happened to this person on a Wednesday for some reason. So on the Wednesday at this point, they always had a low beforehand and they always overtreated. But you would have thought that somebody with this person had maybe 20 years experience with type 1. You would have thought that they'd have understood this, but they didn't. And so this actually was very useful. So where are we up to? So the algorithms, yes, we can translate our hypo algorithms. We can't show patients everything. It's too scary, and it kind of defocuses you. Clinicians like our dashboard, so we've spoken to a number of clinicians where they've done some work for us and they like the dashboard. The only problem in some ways is that we were going to think, let's have a PhD after this, but our developer, Darcy Murphy, if anyone of you know her, she's doing a PhD here in FBMH, was excellent, and so she's done it. There's no PhD to be done. What we now need is a clinical fellow that we're looking for to continue the trial. So we've got a 2-year trial coming up that we want to do next. Deliverables, we've got code running on DigitalOcean, so it can be used. It's sitting there, it's doing stuff, and we've got a paper in progress. Okay, so, and also thanks to the Pankhurst and also the other team of people who were working on the project with us. Okay, thanks. Any questions or? Yeah.
I just want to go out. I didn't quite catch what you were using HyperCheat for previously before you decided to focus on.
So HyperCheat was used. Was used with 10 families whose children had survived the first 2 or 3 days, and now they were, but now they were growing up, but they still had these unknown why hypoglycemic events.
So what's still used for diabetic patients previously?
For people with congenital hyperinsulinism. So the difference is that people with type 1 have no insulin. The shy people had too little.
Okay.
Sorry, had too much. So they were always low. They were always trying to fight lows.
Okay, great. Thank you.
Yes.
Yeah. Couple when you say we, was that an algorithm that automatically contacted patients, or did you do that?
In the first one, the congenital hyperinsulinism one, that is an algorithm whereby we didn't automatically contact patients because we had the clinicians there to make sure that we presented that information to the clinicians. The clinicians then discussed this with patients who were part of the study. However, for this one, yes, we have automated machinery that allows us to send texts, emails, and WhatsApp.
That is good.
Yeah, every week, and they decide when they want it. So you can decide the day you want your report, but it's just once a week, so it doesn't overwhelm them with load.
And the second is one challenge would be automated insulin pumps installed where you automatically have your insulin checked.
So that's yeah.
If that's not on the market for everyone.
Yeah, I mean, with you can have an insulin pump, and insulin pump is about 100,000 people in the UK. That's the target to get insulin pumps for 100,000 people in the UK out of the 400,000 up to yet. But those insulin pumps, even the best that we've got at this moment, can still only keep you in range. It only improves your time in range by about 10 to 16%, and it only It only seems to work well for people who are already 60% controlled. So if you're on any of the vast majority of
That was
people.
not developed with insulin.
No, this isn't developed with insulin pumps, no. And so we wouldn't develop with insulin pumps in this context, because the large manufacturers have already got those insulin pumps there, and we supply our algorithms open source so that they can include them if they like. But you know, this one is really about behaviour change, so that the pump doesn't need to do as much work. Yeah. Hi.
Just a quick question. Thanks for that. It's really interesting. I'm just wondering, did you collect any data about how patients actually responded to receiving this information? Is there any kind of like feedback loop, or what do you expect them
Only
to
for the
do?
shy people. So the shy people, we had a lot more. We had 2 PhDs working on it. One was a clinician anyway, who was doing their PhD in computer science with us, and then another one was another colleague who was a PhD in FBMH. And so the feedback we got was very, very positive. But some people didn't want to change the routines of their children based on the information, which sadly had some negative consequences, because we told one family that this was the problem happening on a Saturday morning, and then 2 weeks later they didn't want to change their routine. 2 weeks later their kid was in intensive care for 3 weeks. Yeah. So most of them liked it. All of them liked it, but some of them didn't want to change routine because they didn't want their kids to have to get up early. This one was the kid normally got up early on a weekday, went to church on a Sunday where they also got up early. Saturday was their only lie-in, but that's the only time that they weren't eating carbohydrates early, so they were producing too much insulin, so they had a very bad low. And they're having lows on that day all the time. Now we could see it, but they didn't want to get their kid up early because it had been okay for 6 months, a year, but then it wasn't. Yeah. But nobody knows why. We don't know why the insulin is overproduced or how. Yeah. Okay. Okay.
Okay, thank you.
Yes.
Brian and Gail, yeah.
Thank you.
Okay, so hello, thanks very much for asking us to come along. I'm Brian McMillan, I'm a GP, Gail's a psychologist, and we've got Gordon Dickie here, who, can I describe you as an expert in natural language processing?
Don't do that.
So yeah, just a bit about, so we got 4 months worth of seed corn funding to help us sort of kickstart a project, which we've called Clarify, or Clarifying Health Record Entries for Patients Using AI. Just a bit of background. So since November last year, all adult patients in England can now see everything that's added to their record from that day on. And that includes the free text entries that clinicians like me type in during your consultations. Traditionally, those free text entries have been designed to be an aid memoir for clinicians, or to pass information on to whoever takes up, looking after that patient after you, and also as a medical legal document. But now that the patients can see what we write in the records, that's changing things a bit. Because it's been traditionally just used for clinical purposes, the free text in records contains a lot of sort of medical jargon and acronyms, so things like SOB instead of shorter breath, or TCI instead of to come in. And unsurprisingly, most lay people don't understand quite a lot of the free text that's in their clinical record, and Gail's done some work that demonstrates that they either don't understand it or sometimes think they understand it but don't really. So that's kind of presenting a challenge, and as a clinician, I've got two options really, is to carry on just doing what I do and hope that patients don't sort of all start ringing the surgery to ask what this stuff means that I'm writing in the notes, or to try and adapt what I write and make it more patient friendly. But doing that would potentially take more time, spelling stuff out. It's going to make the record longer, could make it more difficult to find information in the notes in a busy clinic, because if you've got longer entries, you might miss stuff, so that could be a patient safety issue. So another option might be to develop the tool which would translate the stuff that we write into something that lay people can understand. And that's what we've spent the seed corn money sort of looking into in a bit more depth. Gail's done most of the hard work, so I shall hand you over to her.
Yeah, so I mean, as Brian's just outlined, there are a lot of challenges around implementing this policy in an effective way. And essentially what's happened is a tool that has been kind of created and designed for clinical use now has a new user. So based on some of this previous work we did interview some clinicians, patients and carers from underserved communities and asked them about how they valued this access to their record. And we came out with two really key findings in that, unsurprisingly, clinicians like Brian really value the electronic health record as a way of providing medical legal protection for themselves, and also they see it's pretty essential for giving good clinical care. But when we spoke to patients and carers and showed them some examples of simulated notes, they could see how they could perhaps use this to help them manage their own health more effectively and have more of a say in what's going on. But most of the time, people really could not understand a lot of the clinical acronyms or the medical terminology to be able to use this in a meaningful way. So that original bit of research before this actually aimed to develop some training for clinicians. And as a result of our work that we did with patients and carers, we very quickly realised that really there's too much of a conflict between the different users' needs and requirements. So what we've been doing with this CCORN is starting to work out the feasibility of whether or not it is in fact feasible to create a separate note that will be a simplified version for patients, but still keep this clinical note intact. So we've been using the values and principles of team science. So although we had Goran on board, who's an expert in computer science, and I think Brian and I have got quite a good handle on some of the challenges of implementing this policy and what patients and clinicians might need from something like this, we didn't have a lot of expertise around what some of the legal and ethical challenges might be, how we might manage governing the data and storing the data, and also crucially we needed a partner to be able to get some clinical sort of free text data from. So throughout the course of the CCORN, we had weekly meetings, and through a lot of conversations and meetings with different stakeholders and collaborators, we kept going out and asking people, are we asking the right questions? Has this been done already? Do you know the answer to this? And we came up with three sort of distinct work packages around technical requirements, user requirements, and legal and ethical requirements. We also did some public involvement work. We had a couple of workshops with carers and patients and also clinicians, and that was really helpful to just sort of float the idea, tell them about our overall vision and see what kind of response we got. And people responded fairly positively, but they also brought to our attention lots of issues that we hadn't thought about, although it's all out there in the news. Lots of people were worried about the fact that it might use AI, and we weren't kind of really thinking about that at the time. We were thinking more about the specifics of it. They also helped us to write our PPI section of the bid. The biggest challenge, or one of the biggest challenges we've been dealing with so far, is trying to sort out the data governance. We've had lots and lots of conversations and meetings with different individuals from different departments, and we've come up with a range of short-term potential solutions to being able to actually get hold of the data and run a simulation of it. But in the longer term, this really depends on us establishing a really robust de-identification process that can enable us to satisfy research ethics that we can use this data. So in the short term, we've got an option of simulating the model with a small amount of data and manually de-identifying this data. But in the longer term, we're still exploring a whole range of different options where we could actually have the data here and process it so that we can then simplify it for patients. So whilst we've been doing all that in the background, Goran had a PhD student who's had a little bit of a trial with the notes that we used in our earlier research. And as I was saying, patients and carers found it really difficult to understand. So one thing that kept coming up time and time again in one of our focus groups, people didn't have a clue what no dyspepsia SS meant. And it did a really nice job. It says, you don't have symptoms of indigestion. Likewise, and another note, people really struggled actually with the word with palpation. and that was translated into we felt your neck and didn't find any lumps. Likewise with query esophageal CA has been translated into cancer of the food pipe. So that's all looking quite good so far, but there were a few glitches. The American spelling is quite easy to fix, but what you can't tell from this is this note actually was addressed to a 6-month-old baby rather than mum. So the baby's been told that they didn't react to the smoke alarm. The mum hasn't noticed they've got hearing problems and they're not pulling at their ears, but this is all being addressed to a 6-month-old baby. Brian's going to mention as well in a moment some work we did with some colleagues in Sweden looking at what ChatGPT did in this area. And one thing that comes up time and time again are clinical details being missed when we ask a model to simplify, and this again happened here. So the CRT26 was not translated in the 6-month-old baby version, and it just says C, which is normal. So again, that's another thing that we need to explore in more detail.
So far, the kind of outcomes of the CCAR work, we've engaged with some key stakeholders, and we've established a project team for a future bid. We've clarified and expanded our research questions and got some new challenges that we need to address. There's still some information governance issues that we've got to get our heads around. We've been able to spend the time reading through the literature and looking to see whether what we're trying to do is going to be feasible. And we've trialed some simulated notes. So we've not actually got real clinician free text data yet, but we're close. And the trial that we did with Gordon's PhD student, and we've also collaborated with a team in Uppsala in Sweden, and that's been published in Digital Health. And I wrote just some sample free text entries that clinicians would normally write. We got a team of 6 GPs to sort of verify the validity of that, and then we ran it through ease of reading scores and also looked at the clinical accuracy. And we found that strangely the ease of reading scores actually went up when it was simplified using ChatGPT. There was more empathy in the simulated or in the translated notes. Some of the GPs said some of the notes they would just use them as they were unchanged, but there was some clinical information that was missed out, and there were some hallucinations where the language model just made stuff up that hadn't been said in the note at all. So I'm happy to talk about that paper in more depth later if you want. We've also collaborated with 19 European countries, and the bid's gone in, and part of that bid will be about the use of large language models to simplify clinician free text. So fingers crossed that that one comes off. And we've also identified some other potential funders, such as the EPSRC, and we've written a draft of a grant application for that one as well. Like I said, some of the key challenges. So we're very close to getting a data set of real clinician free text, which has been manually de-identified by our industry partner, Evergreen Life. We're just sort of some contractual issues that we're sort of trying to finalize, like the length of time that we're allowed to have that data for example. In the future, whenever we start training models, we're going to need a much bigger data set. And because of that, we're going to need to develop processes for de-identifying larger free text data sets, and Gordon will be able to answer questions about that because I can't. There are still some information governance and data storage issues to get around. And like I said, future work is definitely going to have to look at how can the clinical accuracy of the notes that are generated by large language models, how can we get sort of regulations in place to ensure that the clinical accuracy of those notes is good enough to be used in sort of day-to-day real life clinical scenarios. Because of that, I suspect it's going to need to be regulated as a medical device. And there's lots of other questions that we're still working out. So would a simplified version go in the record as a permanent thing? And that there's problems with that, because if you ask a language model the same question twice, it'll give you a different answer. Would it be more of an ongoing dialogue where patients can ask questions about things that are in the record that they can see? So those are issues that we've still got to work out for the future. But I think it's quite an exciting prospect that we could develop a tool in the future that patients could use to help them understand what's in the record, because that's one of the big shortcomings at the minute with records access, is it wasn't really designed for a patient audience. So the next steps then, we're going to obviously carry on our negotiations with Evergreen, hopefully get the data set in the very near future. If that's not possible, there are other places where we can get free text from that we've identified now as well. Gail's going to carry on a good work with information governance, discussing some of the sort of legal and ethical issues around using this data. And we're going to finish off that second bid that we've drafted and hopefully get that in the next few months. So thanks very much to the Pankhurst for funding this piece of work. And if anybody's got any questions, direct them to Gordon.
So I've got a couple actually. So first of all, where you've got sensitive data like there, it says, you know, oh, I'm concerned about esophageal cancer. I mean, do you really want to be saying that on a record that somebody might read, such that there's going to be nobody present to sort of talk them through it? Because then if they're freaking out for a period of days before they can get an appointment, that's...
So, I mean, that was a big question whenever Records Access came in. So, I mean, this does happen all the time. So as a clinician, someone will come in and say they're having trouble swallowing, and I will put query esophageal cancer in the notes. And they will immediately be able to go home, log into the NHS app and read what I've written. So the only way really around that is to just be completely open and honest with people at the time they're in the consultation with you, and say, you know, I'm worried this could be cancer. And then whenever they go home and read that, it's not a shock. So it's happening already. And you know, there's been some instances where secondary care doctors have had an appointment with a patient. They're worried it might be cancer. They've written to us to say that. The letter's got scanned into the record. The patient goes home and reads the letter, but they've not actually had the discussion with any clinician yet. So I think there needs to be more safeguards in place, but you know, the government in their wisdom have rolled this out already. So that is an issue that's already there. And the way that we deal with it is just, you know, if I'm ordering tests now, in the past I might have ordered a batch of tests and included one for cancer. But because I didn't really think it was cancer, I wouldn't necessarily have that conversation with the patient. You know, I thought it was irritable bowel syndrome. It might be ovarian cancer. You know, there are 1 in 100,000 chance it could be. But now I make a point of saying, I'm also doing a test for ovarian cancer. I don't think that's what it is, but just in case, so that whenever they go home and Google what a CA125 is, they don't go, oh my goodness, my GP thinks I've got cancer, he didn't tell me.
And then my other one, sorry, was simplification. Are you using any kind of simplification in your stuff like Fleischmann gate levels or that kind of thing to kind of understand what the heck it's saying, really?
Yeah, so we, in the study that we did with the collaborators in Sweden, we used those flash reading sort of, but only to assess the readability of the simplified version, that was just run through ChatGPT. And the reading scores were actually a bit higher for the simplified versions, which surprised me because it stripped out all of the abbreviations and acronyms, and I thought it would be much easier to understand. And I suspect maybe readability and understandability are slightly different things. But Gordon will be able to say a bit more about the kind of simplification tools that we're hoping to develop.
Yeah, so you're right. I guess there is a difference between how easy it is to read and whether you understand the whole thing. So that should be one of the metrics. I guess one of the questions that we have been asking is, what does it actually mean to simplify? It means completely different things to different people. It depends on whether you're a chronic patient or is it an acute episode, right? So it has so many questions. Having said that, I think the technology is not that bad. So it's a funny situation, right? So the technology seems to be able to do some things, even, you know, off the shelves. It does need a bit of fixing. It is more the whole environment, right? So what does it mean that text is simplified? How is that going to work? Is that going to be an interactive thing, or is it one-off? You simplified it, and if you don't like it, sorry, that's a problem. And is it going to be a medical device if it is stored? So all the things around it seems, and getting access to data. Sorry, I forgot the biggest one, which is something that I'm happy to discuss that. So all of these things that are around technology up here, really, I would say, more challenging.
And looking to the longer term, on that point, we are want to explore ideas about personalising it. So what is simplified for one person, as Gordon mentioned, and someone that's got a long-term condition might be slightly different, or people, have a different language or different kind of literacy needs. So there's some real opportunities there as well around kind of really personalising this so that it's understandable to the actual patient.
It's not my area, so I might be a bit naive. But what's in the secure data environment? I know there's some challenges to get in there, but I would have thought it's designed for exactly this sort of thing.
Well.
Well, that discussion. It's not a naive question at all. Right, so we've learned a lot, and I thought we knew a bit before we started, but then this project was really what many projects would do, right, as a cheat code funding. You actually find out where the barriers are and what the problems are. So we thought, right, the data provider will de-identify the data, we'll get it here in a secure environment, whatever the current name is for it, highly restricted, secure, whatever. Well, it doesn't work like that. There are so many things that we have learned we need to do. That's probably something for Pankhurst as well to think about, as how do we streamline data storage, the data that is not the traditional data where right, so it is a set of Excels where you have de-identified them and you have a number that you can put on it.
But you're bringing in data from Evergreen. I mean more, I know these names are mixed up, I mean the secure data environment where we're collecting routine primary and secondary care data from across the Manchester one and the regional one as well.
No one has put the free text in it.
And as far as we can see, none of the big GP record databases like CPRD or OpenSafely have got free text in them. I'm starting to realise why, because there is de-identification is a big barrier to that. And there's a lot of sort of ethical and legal things about, I open up the BMJ on tomorrow morning and find an entry that I've written, but no one asked me if it was okay to publish that piece of work. And that, it's an interesting question, that who actually owns the record? Once the patient's got hold of the record, they can do whatever they want with it. They can put it all over Facebook if they want. And even though, my name and stuff I've written will be in there. So that's interesting in itself.
And there's a problem also that computational infrastructure is not linked to the secure data environment, right? So you can put it over there and look at it. Or if you can put it there, you can look at it.
Courage.
Or it should end on a more optimistic.
Sorry. So download this new one.
Hi everybody, I'm Vicky Palin, a lecturer in maternal fetal health, and I'm here to talk about my project. So this project really enabled myself and my team the time and resources to have collaborative conversations across Greater Manchester health services, and it led to the idea of CardioMama for heart healthy mums. So to give you a bit of a background, pregnancy in itself is a stress test on mums' major organ systems, and unfortunately some mums therefore develop complications during their pregnancy. And those that do develop some complications, such as gestational diabetes, hypertensive disorders of pregnancy, or preterm birth, they actually have a double risk of developing cardiovascular disease in as little as 5 or 10 years after that pregnancy. The risk is slightly higher for more serious complications like preeclampsia, 3 times the risk. But unfortunately, if mums go on and have a subsequent pregnancy and develop an additional complication in that pregnancy, their risk is as high as 8 times, and the window to that event is shorter, so 8 times within 5 years. So what is the solution for this? So we're proposing earlier interventions using the infrastructure and digital data that we've got in the region to actually identify those with the greater risk earlier and help alert the care providers of this risk. Some prior work that I did leading up to the Pankhurst application as well, I spoke to gather insights from the region. So currently, as I said, there's no standardised way of how we identify those at risk, but it seems like the postnatal examination that women have with their GP at around 6 to 8 weeks would be an ideal opportunity for early intervention and sort of those risk factor modifications, so change of lifestyle and diet, to reduce their risk. But public that I spoke to nearly 30 members of the public across Greater Manchester, and in reality they were actually really dissatisfied with their postnatal examinations. They were not very personalised, more like a tick box exercise, and definitely didn't, unfortunately, talk about long-term risk. It was very baby focused, or immediate, how are you recovering from birth, rather than their long-term risks. And out of the women that I spoke to, a lot of them in the room had some of those complications that I mentioned, and their babies were now 4 or 5, and they had no idea about their increased risk. So think about the opportunity that they could have done 4 or 5 years earlier to reduce that risk. Clinicians actually really echoed the frustration, to be honest. It's time constraint, it's like really restricted appointment. There's ineffective systems from that transfer of what happened during that antenatal journey at secondary care into primary care in a timely manner, allowing them to have a conversation with mum about their risks. Excuse me. So there's this need for the streamlining this communication between handover of care and that continuity for patients. But overall, there was a huge enthusiasm about linking up this data, both from patients and clinicians, and using that data to develop risk prediction modelling tools to identify those who are at risk sooner. So that led on to this project with the primary aim to really scope out what the requirements to do this would be. So defining those technical requirements, defining the information governance requirements and headaches, as you might have heard from the previous conversation, but also working from day one with clinicians to help co-design what this tool might look like. We don't want to overcomplicate things. We want to make something that is going to streamline processes and actually aid the way care is delivered. And so in terms of the technical requirements, we are really focused on the data sources, the linkage and the system architecture. So I think most people in the room will be familiar with the Greater Manchester Care Record and what that is. And in terms of the data in there, it's really rich in primary care data, but it's not actually that rich in secondary care data. But what we do have now at Manchester MFT Trust, from September 2022, we went live with EPIC. So this is one singular IT to hold all of the patient records there. And what's great, instead of being paper-based, it's now all digital, it's all coded in standard frame. So what the project really would be, how do we link out this data from EPIC that's now structured into Greater Manchester Care Record to deliver this information to primary care. And this conversation really working with the informatics team at EPIC, talking about how the data might be entered in the user interface, but how is that actually stored on the back end? And therefore, how would we query the back end of that data to extract the information that we needed? So using tools such as Clarity or Boodle. And then in terms of data interoperability, we were talking with partners at GraphNet, who host the Greater Manchester Care Record, and how we might actually ensure that when we are extracting the data, we've got the right accreditation steps in place to make sure that it's secure and compliant. In terms of the information governance, again, it's quite surprise, the standards apply here. You would need ethical approval as well as legal approvals. So put NHS ethics there. You'd need CAG. It would be impractical to try and recruit every single one of the 16,000 births our sites deliver each year. So you need CAG approval to link that data between 2 different separate entities. Conversations were long and complex about MHRA. Is it a medical device if you are just linking up an electronic record and giving that information in a digital format compared to a paper format to a clinical person? But then when you go talk about the notion of a risk prediction tool, then of course you come in. So we have our sort of processes mapped out for getting accreditation. In terms of governance, there are the standard sort of data sharing agreements, data privacy impact assessments, contractual agreements between the different entities, as well as guardian approval of the data to flow between sites. One thing that I would just mention here is some of the challenges. The challenges remain, and this was particularly with reaching some of these and coordinating with some of these women's bodies. And I found that quite a challenge throughout this project in terms of, I can see Brian laughing, in terms of having these conversations. That's all I'm going to say. It was challenging. Although we have mapped out our process of what we think is the standard way, as well as timelines. You know, people can be quite naive how long these processes take. So, you know, the steps, what you would do first, and how long they are going to take in the long run. So, in the final part was clinical engagement. So, I engaged with over 17 clinical professionals in the region for input on what they thought the tool should look like. And we did this by sort of discussing features that they felt would best improve how they communicate with their patients during a consultation. But we even took that back a little bit, rather than saying, well, details about what happened during the antenatal journey. Well, what about if it could just summarise to you in your practice the number of women who are currently under antenatal care and secondary care, the number that have recently delivered, out of those who have been seen postnatally within a recommended time period, and out of them, how many of them are at higher risk of developing cardiovascular disease? And you can see there, 16 out of the 17 said that that would, significantly improve the way they would be able to deliver their care. We also looked at some of the features and asked them to sort of prioritise them. So in terms of Moscow prioritisation, what must it have, or should it have, or could it have? And then when I spoke to the clinicians again, I asked them to feed back on some of these results. And so, surprise, surprise, if mum had a complication in pregnancy, they really want to know about that. But the main focus of this was that, in conclusion, from speaking with the clinical team, was that they needed it to be able to use it. It needed to be quite simple and user-friendly, but also a positive messaging. So rather than just being demanded to do things in a discharge note, more of how that is message and suggestive handover of care, can go a long way. Being. So the benefits of this work are vast. Particularly for me, I've managed to gain an extensive network of collaborations across Greater Manchester. And I've developed close connections with the technical teams at MFT, working with EPIC engineers, as well as I was already working with the clinical data science unit, setting up a virtual environment for research for antenatal data. But through this, we've strengthened our work and expanding, and now talking about how we might be able to bring primary care data into MFT to improve our research. There's been huge clinical buy-in and support, particularly so the Chief Clinical Informatics Officer at MFT spoke with him, and he was really supportive of this project and how we can better communicate between primary and secondary care. And so that's led to a sort of next phase pilot project that we're exploring. So I've listed quite a few sort of things that this has led to there, but I won't go into all of them for the interest of time. But for example, in terms of how we might better improve that connectivity, working with MFT, lead GPs, and an existing software provider in the region, we're hoping that we can actually improve the recording of these clinical events onto the patient record rather than in a discharge letter. We can actually send that and actually have it coded in the patient records as an event, and more standardising, what's happened during mum's antenatal journey. Because if anybody has tried to do pregnancy work in primary care data, it's quite difficult to actually even identify the start and end date of a pregnancy. So can we better improve recording of these maternity events? And this is, we're in discussions about developing follow-on funding for an MRC development pathway gap funding, as well as putting into the trust for a little bit of money to support this development. And then obviously you want to be able to monitor and see what the impact of your interventions might be. So I'm working with the data quality service teams, which run searches across 8 of the localities in Greater Manchester. So, can we see the impact of that improved coding in primary care over time? And finally, the last one I'll mention is the NIHR Challenge funding. So Manchester University is a consortium. We've just got stage 1 funding for this. So all of this work on the data infrastructure that we have for maternity services, we're working up at the moment a way in which we can use these current infrastructures and build on projects like this to really improve maternal fetal inequalities. And so thank you, and any questions? Thank you to Pankhurst, thank you to the rest of the team. And I have a bit of a shameless plug there. I am running a marathon on Sunday and I'm fundraising. One of the charities that I am supporting is Tommy's, the baby and pregnancy and baby charity. So, any questions? Yep. Do it time.
So the idea of forming a dashboard is then useful to clinicians to be able to track patient care. Do you think that once you've developed your kind of pilot for maternity care, would that be easily translatable into other kind of patient scenarios such as cancer care? Or do you think the systems that are behind it all, are they too kind of specialised and it wouldn't? Or so I'm just thinking you could have it for maternity care, but I could imagine there'd be other scenarios where a GP being able to kind of track or follow somebody's journey through a health issue.
Yeah, absolutely. So as part of the pilot that we're testing the interoperability of the 2 systems at the moment, I'm leading on the maternity, and we've chosen sort of gestational diabetes as an event to see the follow-up of women with gestational diabetes. But on the team, we're also looking at people who are on warfarin, for example, and whether not just the coding of a diagnosis, but the coding of test results that are done, say, at the trust, how we can implement and put that into the patient record in a more streamlined process as well. So yeah, absolutely expanding across. But we've chosen a few case studies as part of the team to work on.
I'll just curious about the MHRA.
Yeah.
And could you just say kind of A, where you got to those conversations there, and B, how do they come in at this stage? So I would have thought, you're not doing presumably a pivotal investigation. I would have thought you could have designed the study to not need MHRA at this point.
Yeah, so I mean, obviously this was a scoping exercise in itself, so I haven't actually done any of this work. It was having those conversations. And so from the MHRA, we decided that this potentially would be a class 2A, so moderate risk. But that was only at the point of which, if you were to have a dashboard with a predicted risk on there, but in terms of monitoring and just a dashboard that said this many number of patients, then maybe it isn't a medical device. But the point at which we got to would say it was more the order of, if you were going to apply for MHRA, you needed to have that application in and accepted by MHRA before you put your ethical application in. So it's knowing which one to go through and do first. So we're in the process of applying for funding to make sort of a prototype, and you wouldn't need to put the MHRA application in at that point. But if it was, workable, and then you were at the point where you wanted to implement it, then, of course. So trying to be smart and think, well, apply earlier for it.
And did they do things about, I don't know how it works in MFT, did they do things about quality management and technical file creation? And do you have resource for doing that?
So they have lots of teams that work on EPIC, some that are the technical teams, some of the informatics teams, and they all talk to each other. They have reporting dashboards, for example, that they have to check the data, and it's that, the data is of good quality to then be able to report to the standards to like NHS England and things. I'm not involved in that process, but working with the clinical data science unit for research, very much we do a DQ check of all the data. If we were to create data taking it from EPIC for research studies, then the first sort of few weeks of that is doing your standard sort of data quality. Oh, that's not been extracted right, we need to change the way we've defined that.
Yeah, that's not quite what I mean. It's
Sorry.
not important here. Because even if you're not going for MHRA in your pilot funding, because you don't need it, but if you're eyeing the next one, what you do, the key thing that changes is your technical file creation. Ideally, you want P45 so that you can then just submit. When a lot of people get held up if they don't make it correctly, so they got to do it all again.
And that can be costly in itself as well. So writing into a bid, enough personnel time to manage that documentation, your SOPs and reporting.
Well, it's an ongoing pain with the university that we don't provide more support for doing this and QMS and all that sort of thing.
To my understanding is you've been developing a dashboard for primary care that GPs would look at during postnatal check?
Well, again, we're still working with the GPs to define and co-design.
Okay.
One of the ideas, it could be sort of like a monitoring thing that wouldn't necessarily be at the point of care, or another one could be a knowledge support during the point of care over GP.
So my question would be, at what point would you involve one of the big primary care records providers? Would you sort of get it to the point where, it works and it just needs plugging into one of those two systems, or would you get it on board at an earlier stage? I'm asking for selfish reasons, really.
From another project that I've worked on that we've done this, I would advise getting them earlier. Because in itself, once they're on board, a lot of those quality checks and processes, even if they add it in, this was EMIS that we worked with, it took a long time to get through, a lot longer than we anticipated. So we probably could have started that conversation earlier.
The choice of system, was that just a pragmatic thing?
For that one, it was because they covered a large proportion of the region that we were.
Okay. Thanks.
Can I ask about the EPIC data access? So how did that work? What is the data still in the EPIC warehouse, or does it come to the university, or where was the data?
So obviously I've not done it yet, so I haven't got the data. But for the project, in the conversations that we had, it would be using the existing infrastructure of GraphNet with the Greater Manchester Care Record. So it would need approvals. So for example, sign off by the Caldecott Garden for that data to flow into the GMCR. But then, so it would need to be queried and exported from EPIC.
And there's a comment, I think it's really useful to build these links with CWU, and we should probably as a community try to keep that knowledge. It is not easy to establish links with them and maintain them, because obviously things change everywhere. With people leaving from the unit over there. So trying to maintain these kind of know-how would be really useful.
Yeah.
Community.
They're a really, really good team. They're so overworked and busy, but they're really supportive of research projects as well. And they want to develop and expand. So the more people who work with them, they can show, look, we are bringing in funding, etc., for people working with us. So.
But it would be good that we have from the university side, of Pankhurst side, people who we know are liaison basically with CSDU, so people who know who to ask.
Yeah.
Okay, thank you. They've just got one more project left. Yep, Stephen and Jason.
Glad to see we're not the only double act. So I'm Jason Taylor, I'm the PI on this project, and Steve Paul is here as well. He's going to talk you through most of the details of the methods and results. So this is quite an ambitious title anyway, quite an ambitious project looking at methods of early detection and differential diagnosis of dementias, also a mouthful to say, using functional neuroimaging and machine learning. I think we didn't put a thank you slide at the end, so I'll thank Pankhurst now and our collaborators, Alex Casson, who's in the audience, and Jennifer Thompson, who's our clinical collaborator. Right, so background, it won't surprise you to know that Alzheimer's disease causes memory impairments, causes deterioration of brain regions that normally support memory, as shown here on the underside of underside view of a brain. The medial temporal lobe is what's affected early on in Alzheimer's disease, but also that pathology spreads out to association cortex, sort of spares these primary sensory motor cortex, but it does spread out. And maybe more surprisingly, one of the aspects of memory that's impaired in Alzheimer's disease early on, quite subtly, but it is impaired, is semantic memory, which is our knowledge of word meanings and objects and concepts and how they're related to each other. And so what we're wondering here is whether subtle changes in neural functions detectable by functional neuroimaging can be apparent before changes in brain structure. So before we can pick up, say, atrophy in an MRI scan, we may be able to see functional changes in the brain using particularly sensitive methods. And actually, we've done some of this work when I was a postdoc a long time ago, looking at EEG methods with semantic memory and episodic memory tasks with patients with mild cognitive impairments. We were able to find that if you follow and see whether patients were still stable MCI after 3 years or whether they converted to Alzheimer's diagnosis, if you looked back at the original data, you could actually see and predict who showed abnormal responses, was likely to become a Alzheimer's diagnosis in the near future. This project in particular brings together expertise in cognitive neuroscience, which is what Steve and I are, neuropsychology, which is Jennifer Thompson, as I mentioned, and machine learning and signal processing, which is our colleague Alex Casson. This would have been impossible except as a sort of piggyback project. So Steve was already doing a PhD funded by the MRC, and he was basically doing basic discovery science, looking at the neural mechanisms associated with semantic processing in older adults. And we were kind of hoping towards the end, a few patients. And what the Pankhurst funding allowed us to do was to expand the sample, go into recruit patients, enough of a group of patients that we could really see trends. And the ultimate goal here is to develop scanning protocols and analysis methods that will inform early detection or possibly subtyping or possibly differential diagnosis or even tracking progress and evaluating efficacy of medications as they come available. Obviously, there's been a lot of news lately about different sorts of amyloid removing drugs that have been approved. And it seems that those don't impact cognition as much as we'd like. So although it tends to clear amyloid plaques from the brain, it doesn't really have that improvement of cognition or lack of decrements of cognition that we'd like to see. So part of that problem is probably just administering and detecting early enough, administering these treatments early enough, which we hope we can help with this kind of method. So I'm going to hand over to Steve, superstar PhD student who took time out from his PhD to be a postdoc for 4 months, collect loads of data and do some machine learning analyses and then step back into his PhD. So without further ado, with Steve.
Thank you. Okay, so as Jason mentioned, this is kind of an ongoing part of my PhD. Well, sort of finished now, really. There are parts of this which are definitely more sort of my PhD focus and parts of this which are kind of definitely the focus of what we're kind of talking about today. And I can't have to explain the whole thing for it to make sense. So what happens is we're recruiting Alzheimer's disease patients relatively early in their sort of disease progression. So it's the first kind of, I think everyone was in the first 2 years of their diagnosis. Most people was about between 6 months and a year after their diagnosis. And we asked them and healthy controls to come in for 2 sort of study sessions. The first of these, they do a kind of basic neuropsychological assessment. It's a battery of sort of short tests. It takes about half an hour all in to do, which is very similar to what people might do on their kind of first visit to a memory clinic. It's really just to get a kind of rough idea of their memory performance kind of on the day in general. And then we do an EEG recording. And in this EEG recording, we do 2 tasks. One of these is a semantic similarity judgment task, which is what you're going to hear about today, but in the MRI scanner, and what we call a semantic control task, which I won't be going into. And as Jason mentioned, this is our sort of background, really. I think we're predominantly EEG people, and what this project lets us do is really sort of lean more into the session 2, which is the MRI scanning. So people come in and they get a T1 weighted structural scan. So this is a nice high resolution sort of picture of their brain. And we also do the semantic similarity judgment task, which they do in the EEG session, again in the MRI session. So, what actually is this task and sort of who actually going to do this? So we recruited 32 people to do this, 24 healthy controls and 8 AD patients. In the MRI data set, this is actually slightly lower, given that a few people don't like going in the scanner, basically, and decide kind of last minute they don't want to go in. And also one healthy control who managed to forget them and have a pacemaker until 20 minutes before, which seems quite surprising, really.
At least we got it.
Yeah, at least we got it. So this task we asked people to do, we call it a task, but it's very straightforward. A lot of this, a lot of my research so far has really been about what's the kind of bare minimum we can ask people to do to try and elicit some of the activity associated with processing, semantics, and memory. Given that these people often have quite severe cognitive impairments, not just in memory, but also things like attention and sort of working memory load and things that might make it difficult to do any kind of cognitive task, really. So what we ask people to do is lie in the scanner, and they can see a screen sort of out the top of the scanner, and we ask them to read a stream of words, and these come in word pairs. The first one is referred to as S1, but it's really sort of Q word. And the second word is a target. And what we ask them to do is just read these words and think to themselves, are these related, yes or no? So there are 25 different sort of target words, and they each get paired with 9 keywords. They see these words 9 times each. This means you get 225 total trials. And these keywords are actually split between 3 different categories. So they're either unrelated to the target. So I always use the example, dog, for example. So it's hard to think of an unrelated word on the spot. Spoon and dog, table and dog, let's say, and they think to themselves, no, these aren't related. Or they're related, what we sort of refer to as taxonomically. So that would be, let's say, wolf and dog are 2 items which, or 2 objects or concepts which look very similar. They're very sort of similar types of concepts. And then we also do what I call thematic queuing or context queuing. So if I said kennel and dog, they don't look anything like each other, but we associate them together because they're related in their kind of common context and things like this. And that's really it. In the MRI scanner, we don't ask them to even respond to these. So this is a pretty automatic process. In the EEG session, we do actually record responses to this so that we have an idea about their general sort of ability to process these word pairs. So looking at that behavioral data, patients show an impaired processing of basically all types of word pairs. So that is, they're both more likely to incorrectly identify word pairs as being related when actually most people would consider them not related. These are normed against sort of what people generally think. And when pairs are related to each other, they're more likely to say they are not. However, kind of curiously, they show relative preservation of contextual word pairs. So they're more likely to understand that a dog belongs in the kennel, for example, than a dog is similar to a wolf, which is something that's my kind of PhD focus is about why this happens. But one of the interesting things we can see in this is that on an individual level, this isn't a kind of a high level group level effect. There's quite a clear difference about how patients respond and how healthy controls respond. So if you see a kind of distribution of every response here, we can see that the patients are very much at the bottom end of it. There's not much confusion between the 2 groups, except for a couple of outliers here. So looking at just which parts of the brain are kind of responsible for this, doing a sort of mass univariate F-test or T-test at every voxel, sort of relatively blunt way of looking at differences between these groups, we find that there is an interaction between condition and group in a part of the brain called the angular gyrus. So this is sort of at the sort of back top part of the head, which is a very important part of integrating different parts of information, all kinds of information, but particularly semantic information together to kind of understand what we see in the world. And activation in this area is reduced in patients, particularly in the thematic condition, I think it was. I think broadly for both related conditions, we see a decreased activity in this part of the brain. However, these results are informative on a kind of basic science level, but they are of limited use for developing a biomarker, a particular functional biomarker, given that they simply aren't particularly sensitive. It's not something you'll be able to recreate in every participant, for example. It's a population sort of level effect. However, MVPA approaches, multivariate approaches using things like machine learning or sort of decoding afford us greater sensitivity in comparing patterns, greater sensitivity in identifying differences between controls and patients by comparing patterns of activity either across the brain or within regions of the brain that we're particularly interested in. These are referred to as regions of interest, or ROIs. And by doing this, we can see more on the individual level which parts of the brain are kind of not operating as we kind of expect them to. So based on our univariate findings and results from sort of previous literature and what we already know about how all parts of the brain are informative for processing semantic information, we identify a series of regions of interest across the temporal and frontal lobes. So these highlighted regions on the brain, if you can imagine the boxing glove shaped brain, this is round down the side and on the front of the head. And this light blue section here is actually in the medial part of the brain, so sort of the inside edge of our two halves of the brain. So we use an SVM classifier to see how well these regions can differentiate between conditions within individuals. So the important part here is to say we're not training a classifier to look at the brain image and go, that's Alzheimer's brain, that's human healthy control brain. What we're doing is saying this part of the brain should be responsive to telling the difference between, let's say, our related word pairs and unrelated word pairs. And when that part of the brain isn't doing that, that might be indicative that this person is in fact a patient. So it's not a classifier, it's not a diagnosis machine. It's something to identify brain regions which might be informative for diagnosis. And looking at these regions, so what we're seeing here is that basically a distribution of the ability to determine which condition we're looking at in each part of the brain. So lots of histograms here. Red is our patient group and blue is our control group. And this dotted line is chance. So we know all these parts of the brain are associated with processing semantics, so they all perform kind of above chance in determining which condition we're looking at. But there are a couple of these which are more informative or look like good candidates for regions to look at sort of more intensely or more seriously, which are these two here. So the first of these is the right, so these histograms, the left histogram is the left side of the brain, the right histogram is the right side of the brain. Look at both sides of the brain here. The right sort of middle temporal gyrus, so this is the one on the right here. So I'm saying right a lot here. This is the plot's on the right and the right. Yeah, can you tell mouse here? So this plot here, we can see a difference here. We approach a significant difference between these two distributions here. And slightly bizarrely, we see in the medial frontal orbital cortex, that's the inside part of this brain here, which is a region which came up a bit in our univariate analysis, but perhaps isn't the most sort of first thought of region when it comes to processing these kinds of stimuli. Shows a sort of difference in the distribution between healthy controls and patients as well. And when we break this down, we can see that in the medial temporal lobe, also the middle temporal gyrus, on the right-hand side, we see much poorer ability to classify this in patients compared to our controls, shown by this sort of ranking on the figure on the right here, where this area, which should be sensitive to identifying the difference between these conditions, does not seem to do so in patients. And we also see a kind of reversal of this effect in this frontal region on the left here, where actually this region seems to be over-representing these conditions in our Alzheimer's disease patients compared to controls. So I guess this is a preliminary step of looking at what kind of brain regions might give us kind of functional biomarkers for this kind of thing. Yeah, and I think that's it. On to future actions. That's basically that. So there's still a lot of work to be done here. This is very much a preliminary analyses, and we have a lot of data to work our way through. So I've only talked about MRI data today because that's kind of what Pankhurst have paid for. But we do have behavioural measures, we have neuropsychological assessments, we have EEGs. There's a lot to kind of get through here. And so I think there's a lot of optimization with the data we already have, the small amount of data we already have, to really try and amplify these effects as much as we can. So this includes things like multimodal integration, so trying to take both measures from the EEG and the fMRI and the behavioural data to try and come up with a kind of all-encompassing model. At the same time, I'm particularly interested in connectivity between brain regions. I think one of the benefits of collecting both EEG and fMRI data is one's very good at where things are happening in the brain, one's very good at when stuff is happening in the brain. Both of them together means you can have a very sort of all-encompassing model for this. In terms of actual future research, if we were to get more money and things like this, I think the main thing would be expanding our cohort. We're relatively limited on numbers. I think this has been one thing we learned doing this is there's recruiting people is always tricky, and having a time pressure to it, it makes it sort of definitely tricky. But also I think we kind of underestimated, or at least I think I rather overestimated the amount of people that actually want to do the study. So we see a lot of people come into clinics who, kind of put their names down for things. So they say, oh yeah, I might be interested in doing research. And I think it seemed very possible. And when it's kind of, comes to crunch time, you say, oh, actually, do you want to come in for an MRI scan? And people, start, not so much changing their mind, but, there's a lot of factors that influence whether people come in to do research, basically, including things as, sometimes you bring people and say, oh, do you want to come into our study, and say, actually, I did an MRI scan last week and I can't be bothered to do it again. So try me again in 6 months. So, okay. And equally, I think one thing we found is we did very well recruiting our older patients, who I think they are more willing to sort of take part in research. I think they've got more time to dedicate to it as well. I think when they're a little bit older, and there's people around them are also, I think you notice a big uptick when people get to kind of retirement age and they've got more free time, and the people around them have free time. Also, I think one thing you kind of didn't consider is how difficult the diagnosis process is for younger participants, so the early onset participants, for example, which we hope to recruit. I think the impact that diagnosis has on their life makes them exceptionally difficult to actually get into the lab, basically. That's it. Thank you.
In the interest of time, I'm wondering if anyone could direct questions to you both in the corridor, just because we've got another meeting in here now. Do you mind?
Can we talk to you outside? Is that all right?
Okay, yeah. Thanks so much, everyone. Sorry that we've run over by 10 minutes, but yeah, thanks to all the speakers.